So, good morning, good afternoon, or good evening, wherever you're coming from. Welcome to another edition of LED's webinar series. This month, we're featuring Katie Benyo, and she's going to be talking about LSS opportunities in a clinical lab setting.
This presentation is on using Lean Six Sigma to address 4 of the top cost-saving opportunities in the clinical lab. Some of you may be from the lab or healthcare as a broader industry. Some of you may not be, but I think that some of the takeaways will be relevant for you regardless. I have always been in the healthcare industry. My very first job was at a regional blood center, and probably at that time had no idea I would continue to end up working in the clinical lab area. Prior to my current company, I did performance improvement for a healthcare system in Illinois and Wisconsin, covering all areas of the system. And then in 2016, I came to Acumen, where I am now, to focus on lab operations excellence. I've really enjoyed learning about the clinical lab. Currently, I am a client account lead. I moved into this leadership role a couple years ago after doing project work in lab excellence for a number of years. For those of you who might be outside of healthcare, let's start with what even is the clinical lab. This is a facility that provides a range of tests to clinicians with the end goal of diagnosing, treating, or managing patients. The lab is run by scientists. They are very highly trained. It's not an entry-level position by any means. They are analyzing the tests and looking at the specimen to aid the provider. The lab does also employ phlebotomists, which are people who do the blood draws, lab assistants, histotechs, pathologists who are physicians, and then, of course, lab managers and lab directors. Most labs that serve a hospital population are situated either in or nearby the facility so that they can provide access to the clinicians there and to their patients. And lab is a huge industry in our country and internationally, but healthcare systems across the US perform about 13 billion tests per year. And many of you have probably experienced lab services either through yourself or through a loved one who might have been a patient at some point. Of course, the COVID-19 pandemic, which was an unprecedented demand on healthcare resources. There were significant increases in workload for send-out lab tests and for COVID tests. There was actually a net decrease in overall demand across nearly all other lab sections. And so cash flow at our nation's labs crashed. Revenues were down by billions of dollars within a matter of months. Statistically, the drop in specimens was about 50 to 60%, and lab revenue fell by similar amounts. Now, those labs who are performing COVID-19 testing did get some revenue for that, but performing those tests was really not enough to cover the drop. That was about 20% of their pre-pandemic revenue. There were also a lot of challenges with performing the COVID-19 testing. There were supplies shortages, workforce shortages, and a lot of smaller labs were not able to perform COVID-19 testing and earn that revenue. They had to send that testing out to be performed elsewhere. Consider Lean and Six Sigma collectively together. But if I had to boil these down to 4 key points, they would be these. 1 would be value creation for customers. Lean Six Sigma can be used to increase customer value by delivering what the customer values and is willing to pay for, and then eliminating the other non-value added activities or the waste, and continually working on improving processes to enhance that value. Minimization of waste. This is a main focus of Lean. Minimizing variability and waste in business processes creates more continuous flow between each step. A core concept would be reducing defects and variability. Six Sigma uses a really structured approach to do this. You start by identifying the defects or variations and then look at the root causes of those and then work to improve on those. And then lastly, creation of financial savings, increased revenue. Organizations that use Six Sigma principles are able to sell more, manufacture more, deliver more quickly. So increased revenue, but also, of course, decreased costs. Production costs are going to drop when Lean Six Sigma is applied to an inefficient process. As we're reducing defects and errors in the production process, then we are reducing rework, and therefore we're consuming less time and less company resources that don't add value. If we can remove unnecessary steps from the production process, then we should see decreased cost. All right, so we understand the history of clinical lab reimbursement decline and why we need to target lab costs for reduction. We have little control over the revenue side, and so we need to focus on the cost side. And we understand the philosophies of Lean and Six Sigma. So how then do we apply those to improve? We are going to cover the top 4 areas of cost-saving opportunities, which are the lab testing itself, lab labor, lab equipment and supplies, and I would lump reference testing in there as a supply in a sense that's purchased. And then finally, blood products, which if you don't know a lot about is a pretty interesting area. So I'll go into each of the 4 of these in a little bit more detail and define how we can use Lean Six Sigma concepts to take these from a cost to an opportunity for improvement. So the first one here is the lab testing. The demand for lab services is increasing, but a lot of money is spent on tests and procedures that do not actually improve clinical outcomes. Inappropriate tests make up the bulk of waste in medical spending. Specifically, some of the numbers, studies have looked at insurance claims and found that 10 to 30% of lab tests that are performed in the US are either unnecessary or inappropriate. There is no correlation between the volume or cost of ordered tests and quality of care. This cost of lab testing can be minimized through what we call a lab stewardship program, or some organizations call this test utilization. Lab stewardship is a more comprehensive term. Lab stewardship is defined as the careful, responsible, and evidence-based management of lab resources by reducing clinically unnecessary lab testing. A methodical lab stewardship program will result in increased lab capacity, reduced lab expenses, and therefore maximized organization profitability. But of course, it also improves patient care. Correct patient testing improves diagnosis, and lab stewardship also reduces blood collection among patients.
Do you have an example of unnecessary lab testing that is common practice?
A lot of it has to do with the frequency of testing. If you're an inpatient staying overnight in the hospital, often providers will order a CBC every day. A patient may be in the hospital for 30 days and get 30 CBCs. And is the clinician actually looking at the result of that every single day? And if they are they making changes to your course of treatment because of that test result? The answer is not always yes. So something as simple as that, people get electronic workflows in place to easily and quickly order these tests, but they're not actually being used. And so those high frequency tests are opportunities that can be looked at.
Interesting.
Genetic testing is a big area. Molecular testing has a lot of overuse, especially post-pandemic. There should be algorithms in place to identify whether a patient likely has flu or COVID, and sometimes those are overused where we test for everything and it's not actually going to impact treatment. Another big opportunity would be looking at tests that are called limited clinical utility, meaning it's become obsolete or out of date. There's a better test out there that's more accurate or tells the provider more information about the patient. And sometimes providers are just not up to speed on the latest literature. They might not know that there's something better out there that oftentimes costs less and could be used, or they may be using 2 tests together in tandem when only one will do.
Also, that was from Beth Robinson. Thanks, Beth. And then
Yeah.
Frank made a point. He said, should not government agencies reimburse based on the most efficient lab processes available versus the average?
Yes.
He says, using the industry. I don't.
The short answer to that is yes, they should.
Now we need to make some policy changes here. And then I think that's it. Michael Baker, he wants advice on how to advocate for removal of low frequency tests.
That's a great question. Low frequency tests are also in a different way. When setting up a lab stewardship committee, one recommendation would be, as you're getting the group of clinicians together, to start by focusing on something that they are passionate about. Maybe there's a workflow that's inefficient for them and it's challenging for them to order the test that they want to order. If you can start by showing success in an area like that and see improvement quickly, then people will be more on board with continuing the committee to focus on larger areas that are maybe not something they're already aware of or even their preference to change, but we need a quick win that people are happy about to get the committee going. That's a good place to start.
Yeah. And then Race is wondering, it's great presentation, but is there any reason why we're focusing only on blood versus other type of samples, urine, etc.?
This would include all, yes. Urine
this
samples,
does include all, not just blood.
I mean, even outside of the clinical lab, in the anatomic pathology lab, where you have different types of specimens, lab stewardship can include all areas, not just blood samples.
Okay, thank you.
All right, thanks for summarizing the questions for me. I'll move on to the second opportunity cost that we will talk about. The biggest cost for most clinical labs is staffing. According to a recent survey, labor expenses constitute over 60% of the total operating budget of a clinical lab, and that would include not just salaries, but also benefits. And labor costs, of course, then significantly impact the profitability of a lab or even the organization as a whole. And so it's really important to understand and manage that expense. Lab labor cost per test is a metric that's often used to measure efficiency. And as anyone who's in the lab industry will know, there's actually a really significant shortage of qualified medical lab scientists today. And so this increases costs through turnover and also just through wage competition with competitors, as everyone is trying to get these same scarce resources. So for this reason, it's really important to not only have continuous improvement in place, like Lean Six Sigma, to make the best use of your current staff, but also to actually then capitalize on the time and labor savings of that process improvement. Labor optimization is a long-term strategy to right-size your labor pool to the amount of work that's needed to support the business. So as your organization does continuous improvement, whether it's Lean or Six Sigma or another methodology, successful projects should reduce the workload for staff, and then the labor pool can shrink over time while still maintaining or even increasing quality and service standards. If the organization is seeing an increase in the volume of service provided or just would like to pursue one through growth, then right sizing might look like maintaining the current labor pool while you grow the business. And if volumes or business are stagnant, then right sizing can be achieved through attrition, not a reduction in force. There are 4 key components to successful labor optimization. Those would be, of course, number 1, the continuous improvement itself. Next would be establishing labor oversight, data analytics, and then what I am calling countermetrics, meaning looking at things like quality and service to make sure that as we optimize efficiency, we're not negatively impacting quality, or as we minimize the labor resources that are needed on a process, that we're not negatively impacting service or turnaround time to providers and ultimately to patients. We'll look and see if there are labor-specific questions. I don't see one, so I'll go on to the third bucket, which is lab equipment and supplies. Healthcare lab supply chain costs are rising over the country. The average supply cost increase over 2019 to 2022 was 18.5%, which is outpacing inflation by nearly 30%. And lab services specifically, expenses saw an increase of 27% over that same time frame. Lab is also a very small department in the hospital, only 3 or 4% of the total supply chain. And so often a hospital will not have a dedicated team to focus on the lab supply chain. Equipment and supply contracts are only renegotiated every few years. With renegotiating contracts, And clinical changes have to be really carefully considered in the lab, because if you don't have buy-in from clinicians about recommending a change in product, or if you haven't truly looked at the impact that it might have on patients, that clinical change is not going to go well. So there are a lot of complex factors involved in looking at the lab supply chain, but there is great opportunity to reduce costs here, even while improving performance when looking at lab equipment and supplies. If the hospital does not have a dedicated team of experts focused on lab because of it being a small department, they might want to seek out an expert in this area. Really, what is needed is robust market data and lab product and vendor knowledge to be able to go after those cost savings. Regarding reference testing cost, targeted insourcing or outsourcing, or kind of that make versus buy decision, should always be looked at first. Should we be doing something in-house when we are sending it out to a reference lab to be performed, or vice versa? For the reference labs that you are using, you can often consolidate testing between them to achieve better pricing, and reference cost should always be benchmarked so that you know if you're getting something that's keeping up with the market. And all of these decisions need to be made based on data, demand, capacity, and the equipment that you may or may not have in-house, as well as the people that you may or may not have in-house to perform that testing. A little bit more on this, that benchmarking of all categories. You're going to want to look at different sites with similar spend. And final bucket that we'll talk about is blood products. And if you don't know a lot about this area, it's pretty interesting. A blood transfusion occurs in the US about every 2 seconds. In patients over 64, it's the second most common procedure performed in hospitals, and in a slightly younger age group, it's the 5th. But overall, it occurs in 3 to 5% of hospital stays. And a lot of hospitals right now are trying to reduce their blood product costs for a couple of reasons. One is that there have been recent shortages of blood products. Maybe you've seen that on the news, or you've seen some of the pleas by the Red Cross blood centers asking for donors to come in. A very low percentage of the population who is able to donate blood actually does. And so it's a very scarce and precious resource. There have also been increases in blood product pricing. And unlike the other lab supplies that I covered on the previous slide, there's really not a lot of opportunity to negotiate for better pricing on blood products from your vendor. So while hospitals are looking to reduce those costs, an opportunity that they often overlook is that the best way to reduce spending on blood products is to focus on the appropriate utilization of those blood products. In the US particularly, we have a lot of perceptions around blood. We think that transfusion is rare, that it's safe, that it's not risky, that it contributes positively to patient outcomes. And the reality is that transfusions are actually very common, as I showed in the numbers over there on the left. It is risky. Blood products are not always available. They are often associated with poorer patient outcomes, or they're at least ineffective for the purpose that they're given, meaning we only introduce risk without introducing a lot of value for the patient. There is a small number of patients who do indeed have their lives saved because of receiving a blood transfusion, and I don't want to minimize that. But there are a large portion of patients who may receive questionable or no benefit. They may receive mostly risk without any benefit. And there are some patients who even die from receiving a blood transfusion. So patient blood management is becoming a very important initiative internationally. This is a program that typically involves many different disciplines across the hospital. It is not just a blood bank or lab focused initiative, but you need providers and other clinicians involved. And patient blood management is all focused on the responsible, safe, effective, and optimal use of blood products. One of the 4 core components of patient blood management is also anemia management, meaning preemptively having strategies in place to manage a patient's anemia before they even get into a situation of possibly needing a blood transfusion during a procedure. But overall, this is going to not only reduce the cost of blood products for the lab and the hospital, but significantly improve patient care, which is really the reason for most organizations doing this program. Lab reimbursement decline necessitates this targeting of lab costs, and in line with Lean's goals to create more value for customers and to minimize waste in processes, and Six Sigma's goals of financial savings with improved quality, these are 4 areas of focus for the clinical lab that benefit from applying these principles. I do have my contact information in here if anybody wants to give feedback on the presentation or has further questions for me. Please feel free to reach out, or if you just want to connect on LinkedIn and keep up to date with what each other is working on, that is always welcome too. Is it common for the lab industry to have standard work in conjunction with Lean and Six Sigma? Standard work is very important to have in the lab for your accreditation and policies and procedures. You're going to have to define how you do your work, but standard work, as I'm sure you know, is a little bit different from that. We do a lot of continuous improvement work to try to identify the single best way to do something and then to document that and make sure that everyone is doing it that way. Oftentimes there's variation between people, between shifts, and so standard work is an opportunity. Many labs have standard work in place, but many also have the opportunity to improve on that.
Well, lots of great comments here, Katie. I don't know if you're able to look at all of them. There are a couple of questions. Somebody threw in a reference to mod apps. So that was a 2-minute rabbit hole that I dove down while you were talking.
Mod apps. I am not familiar with that acronym. I will have to Google that one as well after we hang up here.
Based on my 2 minutes of research to a MTM, or motion time survey kind of stuff, where you're looking at movements and assigning a certain time to them. In this case, the movement for a single, like a thirblet almost, is 0.129 seconds based on lots of research apparently. And it's a convenient way of evaluating the effects of changes in workflow without actually having to. So it's an easy way to simulate the results. So very cool from that regard. Somebody else was asking questions about what the uptake of in a lab is. Is it common for the lab industry to have standard work in conjunction with Lean Six Sigma?
The standard work I spoke to, general Lean Six Sigma in the lab, often healthcare organizations may or may not like to use the words Lean and Six Sigma. Sometimes they have continuous improvement in place, but try to stay away from those buzzwords. I would say it's mixed. You know, there are certainly healthcare systems across our country who are the shining star example of having continuous improvement in place, and that would extend across the organization to improve the lab. And then there are organizations where it's a big opportunity. Healthcare industry as a whole, it's still a huge opportunity. Healthcare is always late to the party. So when Lean and Six Sigma came into manufacturing, the uptake was not there in healthcare right away. So it's pretty mixed. And I would also say specifically about the lab, it does not get a lot of attention, and it does not get the attention that it deserves. I think prior to the pandemic, hospital leaders knew they had a lab. Now they might actually know where it is. It's truly often physically in the basement, you know, with no windows, and people forget it's down there. They collect their tube of blood or other sample from a patient, and they tube it to the lab, and they have no idea what happens on the other side of that wall until they get their lab result back. So the lab is a really underappreciated area. And for that reason, I think sometimes even the great continuous improvement programs that a hospital or health system may have in place do not always make their way into the lab.
So Katie, I'm curious. Most people's experience with change is when it's been done to them, or imposed on them from the outside. So how do busy lab managers feel when someone like yourself might come in and say, hey, we're here to help make your job better? They're looking forward to, or how do you get over that?
Some good leaders are open to help and open to improvement, and others are very resistant because they might think that continuous improvement means that I'm not doing a good job today. If you're implying that I can improve, then what is that saying about me? So we do get a mix. I think laboratorians, while some people perceive them as far removed from the patient, they are very patient focused. And so typically a winning argument with a leader in a team is to bring it back to the patient. How is what we are doing improving care for them? If it's about improving turnaround time or quality, that's an easy connection. If it's about improving efficiency internal to the lab, it's a little bit more of a stretch that we have to talk through, but bringing it back to the patient is helpful.
Sure. Well, and the way I try to sell improvements is to say, look, you probably have job positions that are vacant right now, right? You're trying to hire people and they usually nod yes. Say, well, here's a way that you can reduce overtime or get people home for dinner on time. So that seems to help.
Yep.
Frank asked a question here, and he's asking about the changeover times, batch size reduction, work balancing methods. Are they applied to CI in the lab? So just some of the typical lean type principles. Obviously.
Yes, typical lean Six Sigma. To be honest, if there's any area of healthcare that is somewhat similar to manufacturing, I could almost argue that it is the lab, and laboratorians would not want me to say that. But there's a lot of technology in the lab. There is a lot of automation in the lab as well. So loading instruments, anything that you could apply to a machine in another industry, you could look at the same sense here. Batching is different. I know in any other industry, batching is a dirty word that we don't want because it increases individual turnaround time. Sometimes it is more efficient to batch in the lab because if you only get a few of a particular test throughout the week, it doesn't make sense to run them as they come in. So there might be, 2 days a week that we do this particular test that's very complex and manual, and it's more efficient to do that way. So that's a little bit different. I see a couple of comments about technology. Someone just asked about AI. Like I said, there is a lot of technology in the lab from, loading instruments on a line that can receive it into the lab through a barcode scanner, spin it down in the centrifuge, carry it all the way across the room and put it on the correct analyzer that it needs to go on, prioritize a stat specimen in front of a routine specimen. That's pretty basic technology that exists in the lab and has for years. And there are also some really new and exciting things. AI is already used in pathology and among hematology techs as well for differentials. I see that as a good thing. If it can help a pathologist to look at something in a microscope, it can already give you a guess of what they might be looking at so they can get to that answer more quickly and more completely. I think that's a great thing. Of course, there are going to be people who are skeptical or are scared by that, but think about some of the things that we're doing today that we were not doing years ago and now we think is commonplace. I'm sure that's how this is going to go as well.
Absolutely. And I know there's some concern about turning over decision making to AI. So I like what you said about using it as a pre-screen, not as the arbiter of, is it a positive or a negative test?
Yes, use it on the front end, not the back end.
So that's interesting. I'm sure that's a whole big, you got to talk people off the ledge for that, like they're ready to jump to conclusions, perhaps. Somebody else was asking, Grish was asking, what's the next highest cost contributor after labor cost typically?
It probably depends on how you slice and dice things. It's either the testing itself or the supplies and equipment, depending on what you put in bucket. But those, along with labor, are going to hit the majority of the costs of the lab.
Somebody else was asking about work related to lean leadership, lean thinking, or Gemba concepts in the lab. Ooh, a lot of good questions here.
It's important for the leader of the lab to understand continuous improvement and be on board with it, or it's not going to be successful in rolling it out to staff. So definitely need to have that in place. And walks are absolutely a great idea because the lab is a physical space where things are occurring. It's not always just an electronic process, right? So there are physical spaces to walk through and look at the work being performed by people who are moving about that space. And that's a great practice to have regularly.
Okay. Couple of questions. So somebody was asking about the measurement systems analysis, both types of gauge R&R, variable as well as attribute, which I love that question. Thank you very much.
Yeah,
Go ahead.
MSA, they may or may not call it that within the lab industry, but to even be an accredited lab, there are a lot of procedures in place to validate that the testing that you're performing is accurate. That is like the baseline. I would not call that continuous improvement. I mean, you have to have accurate testing in place to begin performing testing for providers.
Somebody else asked a great question about, do you have any examples of countermeasure metrics for labor optimization?
Yes, so those would fall into two big buckets of quality and service, meaning turnaround time. For turnaround time, you can slice and dice it in a few different ways. You can look at collect to receive time, receive to result. Each of those components are important to look at separately so that you can see where the bottlenecks are happening. So turnaround time of results to providers and ultimately to patients. And then under quality, rejected specimens is a huge, that happens among the root cause of that is among the phlebotomy and nursing teams who are collecting samples, and they have huge impact on the rest of the process on down the line. So very important to have good collection and identification processes in place upstream. Other areas would be things like blood culture contamination, corrected reports. I would say those are probably the biggest.
Interesting. I'm thinking that really is just to balance out so that you're not optimizing one metric at the expense of the system. Is that right? For instance,
Exactly. Yes. As we're trying to
if
optimize efficiency and minimize the amount of labor resources used, we want to make sure that we're not negatively impacting the quality of the testing nor the ultimate turnaround time that we can provide it.
right. So, for instance, I mean, you might look at turnaround time as a measure of efficiency or effectiveness, if you will, and then looking at labor utilization, right? I mean, after all, if I've got technicians on standby, by golly, we're going to reduce turnaround time at the expense of labor, obviously. How'd you get into this business? What's your origin story? I mean, were you a science major in
And I'll give
university?
it to you in 1 minute because I just looked at the time and noticed that's about all we have. You know, I always knew I wanted to be in healthcare because I wanted to improve patient care, but I did not want to be clinical, did not want to be a doctor or a nurse. My mindset is better fit for the business side of things. And to be honest, I didn't really know that continuous improvement was out there, let alone a career path. So I had a Six Sigma green belt class when I was getting my master's degree, but it really wasn't until I went to work at a healthcare system and went through their internal green belt training where I did a real life project that I became more interested in it. So from there, went through their black belt training, got my ASQ black belt certification, and on from there. But to be honest, didn't even really know that quality improvement was a career field, which I think is probably the case for many people who stumbled into it.
CI and quality, yeah, there really aren't many, not many more than maybe two programs that are designed to give you a degree in either field. So it's one of those things. It's most people get to it from other places. I think it's kind of cool in that regard.
I flipped back to the slide with my contact info on here. So if anyone would like to reach out and share their thoughts, please do. No, thank you everyone for joining the presentation and especially for being so engaged with many questions. That means it's a topic of interest.
All right, folks, you can spend your time in lots of ways. So we appreciate you spending the last hour or so of it with us. Good morning, good afternoon, or good evening, wherever you're calling in from. Enjoy your day. And I will send out the link to everyone, folks, if you're still there. All right, folks.
Sounds good.
Nice job, Katie. Thank you.